Thank you for the kind introduction. And thank you everybody for continuing to stay back till the last talk today. I assure you that you will not be disappointed. Let us begin. So today I'll be talking to you about this topic, communicating benefit versus risk to patients who are at mild to moderate risk of cardiovascular disease on the topic of commencing statins. Because if they are at high risk, then it won't be a question. But it is, this group of patients who are somewhat at the twilight zone that, we face a lot of difficulty. So who here has never debated statin initiation in people living with HIV? I believe most of us would have asked ourselves if the person in front of us require any statin or not. On more occasions than that we wish, and most of the time we could be having a genuine dilemma. So today, we'll explore the cardiovascular risk of HIV, review some landmark trials on statin use, especially in this cohort of patients, and as we go along, we discuss a case that might resonate with your clinical experience. So before we start, let's have a look back at how history discovered this unique relationship of cholesterol and its association with cardiovascular disease. It was first discovered in the 18th century by this man, François Poletet de la Salle. So it was discovered in gallstone cholesterols, and it was brought on 2 centuries later by this Russian man, Nikolai Anishkov, who established the lipid hypothesis, linking dietary cholesterol to atherosclerosis. Then in the 1950s, we have this Framingham Heart study. I'm sure many of you would have heard about this study before, that elevated cholesterol levels were critical risk factors for coronary artery disease. 2 decades forward, discoveries of LDL receptors by these 2 gentlemen, Goldstein and Brown, which earned them the Nobel Prize in 1985 in physiology. They discovered that indeed cholesterol is associated with cardiovascular disease. Yeah. So in your practice, how often do you assess cardiovascular risk in HIV patients? Or have you ever? So this is the time that we have to look at our practice and to start asking this question in our HIV patients. Let's switch gears for a moment by looking at the case. So this is Mr. B. He is a 50-year-old man. He's on long-term antiretroviral therapy. He is on Tenver-M and dolutegravir. And his CD4 at the moment is more than 500 and viral load is undetectable. He is a smoker. His LDL cholesterol is 3.4. We know that this is higher than the 2.6 that we always want to target. And his high sensitivity CRP is raised. He also has a family history of coronary artery disease. So in him, would you start statin? Yes, I hear a lot of yes. So initially I had intended to do a poll, but because of the limitation of time, I guess we will have to skip that part. Then, if you will want to start statin, which one? Yeah. So again, I intended to do a poll, but because of time, we have to respect that. So anyway, 4 options, which is commonly available in most of the hospitals in Malaysia. We have atorvastatin, pitavastatin, rosuvastatin, and simvastatin. Of course, simvastatin is of the older generation, which we try to not use it if possible. And we can choose to start the other options. Then come the question of when do we choose, what do we choose, right? Coming back to Mr. B, he's a sad 50-year-old man. So how can statin benefit me, he asks you, looking you in the eyes. Okay? And then he asks you, which is a valid question, is it not another pharma gimmick to drain my retirement fund? Where his money will be spent on more drugs. It's a valid question, right? So let's explore the relationship in more depth here between HIV and cholesterol. So it is more complicated than we think they are. So the risk of atherosclerosis disease has to be explored in order to answer Mr. B's question to you, right? So the risk of arteriosclerotic disease is twice as high among people living with HIV as compared to the general population. I hope all of you can still remember what is the pattern of ECG here. Well, it's STMI, yeah? So it is twice as high in people living with HIV. And this graph shows you the relative risk of myocardial infarction or coronary heart disease in people living with HIV when compared to non-HIV populations based on multiple studies here. So based on these multiple studies that we have over the years, the result is persistently consistent. So the dotted line here indicates the relative of 1. So when you compare with the general population, all of these studies shows a raised risk of coronary heart disease in patients with HIV. Then we ask ourselves, why? Why is the data showing the way they are, right? Then we have to explore a little bit further, deep dive a little bit between the relationship of HIV and cholesterol. What is happening? So it is a complex interplay between the HIV virus along with antiretroviral therapy and also the host factors. So on the first factor, the virus itself is actually causing chronic inflammation in people living with HIV. It also causes a lot of chronic immune activation, systemic inflammation. As a result of that, alters the lipid metabolism by decreasing the HDL, increasing the triglyceride, and also causing a raise in LDL. And even if the patient is started on antiretroviral therapy, the immune activation is still persistent. And despite the HIV individuals may have undetectable viral load for years, but the systemic inflammation and the chronic subtle inflammation is actually still ongoing. How about the impact of antiretroviral therapy to this effect of coronary heart disease? So ART will induce, some of the ART more than others, will induce metabolic syndrome. Some of them will cause insulin resistance as well as lipid abnormalities. And this is especially true in the class of protease inhibitor, whereby it is associated with dyslipidemia, including elevated LDL, triglyceride, and reduced HDL. NNRTI is another common culprit. For example, efavirenz is linked to higher triglyceride, but it is still less compared to protease inhibitors. Integrase inhibitor, which are, for example, dolutegravir or raltegravir, actually shows more favorable lipid profile, although a little case reports here and there have been reported of increase in LDL. So this is a very interesting bar chart that shows the different combination of antiretroviral therapy and their impact on the cholesterol levels. So over here we can see the total cholesterol, LDL cholesterol, HDL cholesterol, triglyceride, and the ratio of total cholesterol as compared to HDL cholesterol is being measured and is being compared. So I hope you can see this chart, but to summarize, what we found from the different combinations are the ARV regime that has efavirenz in them has the worst overall impact on lipid levels, with the highest increase seen in the total cholesterol, LDL, and also LDL. So this may suggest that, efavirenz containing regimes poses a high risk of cardiovascular issue compared to the other regimes. This is very important for us in this region because there are still many countries, including Malaysia, we are still using efavirenz-based regime as one of the first lines therapy in people living with HIV. All right, so having said all that, how do we assess a patient's risk of getting a cardiovascular disease, right? There we have a few scoring systems that I'm sure all of you would have heard of, like the Framingham risk score for coronary heart disease. So these scores we estimate a 10-year risk of heart disease in patients aged 30 to 79 with no history of CHD or diabetes. We also have this ASCVD, which we use in our clinics, that they look at more traditional, the traditional risk factors, including the epidemiological factors like age, gender, LDL levels, and so on. In the European countries, on the other hand, they have this score, which is a tool also to look at, to risk stratify people, on their risk of getting coronary heart disease. However, the problem with such scores are they underestimate the risk in people living with HIV, right? All the tools that we are familiar with over here actually do not take into consideration the factors that people living with HIV has, such as the chronic inflammation, the immunomodulatory factors, the antiretroviral therapy, and so on and so forth. So those factors are not taken into consideration. As a result, many of them who requires therapy to reduce their CVD risk is actually not getting it because the risk is underestimated. So what should we do? So when we look around, there are actually a few new tools that has been developed, but it's not really validated in a certain cohort of patients yet. For example, the DAD score, the data collection on adverse effects of anti-HIV drugs. So this scoring system includes both the traditional risk factors as well as HIV-specific risk factors, including certain antiretroviral drugs. And it provides a 5-year risk prediction of CVD, right? The next would be this Veterans Aging Cohort Study. This is another tool which incorporates HIV-specific parameters, including CD4, HIV viral load, and it predicts mortality, right, in cardiovascular disease as well. So now, there are tools here, but can we use them? How accurate are they? Are they validated? All right, so there is this study by the Germans. They actually compare the predictive value of DADR score versus the European SCORE tool and also the Framingham CVD scoring system in HIV population in German. So the result of this is compelling that by using the traditional scores, they are actually underestimating the risk of CVD in HIV patients, right? So therefore, using the scores that include HIV-specific parameters, in fact, should be considered in our patient cohort for more accurate assessment. Switching gear, let's look at this landmark trial of REPRIEVE. So this is a landmark trial on statin use in HIV patients, right? So this trial was started in 2015 until now, and by the objective of evaluating statins for primary prevention of CVD in HIV patients. So there are a few major strengths of this trial, which include the enrollment of participants from multiple sites globally, and also the inclusion of large numbers of women. They are using pitavastatin, 4 mg, versus a placebo. So the key findings, it shows that statins reduce MACE, major adverse cardiovascular event, significantly. So how much significant is that? It shows that there is an achievement of 36% reduction of the primary endpoints of MACE over 5.6 years. As we can see from this chart, the MACE that is measured included MI, stroke, cardiovascular death, coronary revascularization, peripheral arterial disease, hospitalization for unstable angina, or death from an undetermined cause. The result has been consistent, and this illustrates the cumulative evidence of the first MACE and also the first MACE or the death when we compare pitavastatin cohort versus the placebo cohort of patients. So consistently, over 72 months, the cumulative incidence of the first MACE and also the death incidence due to cardiovascular events consistently shows effectiveness in reducing cardiovascular risk in this population of patients. So now we have gone through REPRIEVE. So how do the REPRIEVE findings, tell us about, and how can we adapt that to our management of HIV patients? So from that study, we know that the pitavastatin study is generally safe. There is no significant effect on liver function, and there is also no severe high-grade muscle problem from there. We are looking at Jupiter trial. I'm just highlighting some points here. So this trial is looking at rosuvastatin in patients with raised LDL and also raised CRP levels. So the significance of these studies is that it shows that by giving rosuvastatin in patients with raised CRP, it actually reduces the CRP, which is a reflection of inflammation, which happens a lot in our HIV patients, as we know. And by doing that, it also reduces the risk of coronary vascular disease. So I'm trying to extrapolate that to our cohort of patients who has prolonged inflammation in their body because of the disease process of HIV, despite the viral load being undetectable, right? So this is one of the study that shows that statin can reduce this inflammation. Coming back to Mr. B, our favorite guy. So he's concerned about the side effect of statin. Who wouldn't, right? And he asks you, will I get diabetes if I were to take statin? It's a valid question. And is it a real risk? So looking back at the REPRIEVE trial and a few papers, statin does show some increase in DM in the cohort of REPRIEVE patient. However, the increase is not over the general population. It's similar to the general population. In fact, the MACE were low in those on the pitavastatin group with diabetes versus those on placebo on diabetes. Okay? And the diabetes was induced only mainly in the population where they are already pre-diabetic. So it's not like they are the statin is inducing diabetes in patients who are non-pre-diabetic. Okay, I hope I'm clear. All right, so it's all down, dark and gloomy again for Mr. B. He asks you, what if I take it and I get dementia? I heard, from my uncle that if I take statin, I'll get dementia. So is it true? So let's look around for some evidence. So there are some meta-analyses and cohort studies. Actually, statin is associated with reduced risk of dementia. And I've listed down a few meta-analyses for your reference. And on top of dementia, statin also is found to be protective, or it reduces the incidences of Alzheimer. Wow. So these results confirm the absence of this neurocognitive risk association with statin treatment and suggest, in fact, a potential favorable role of statins. So there are also other potential issues of statin use, especially in our patients living with HIV. We need to consider the adherence because there will be an additional pill or two when we start the patient on statin. The problem of pill burden is real. And also, don't forget about the potential of drug-drug interaction between the antiretroviral therapies as well along with the statin. Let's explore DDI. DDI is a problem. So we know the simvastatin, lovastatin, and atorvastatin, all of them are actually metabolized by CYP3A enzymes in the liver. Less so with atorvastatin when we compare with simva and lovastatin. And protease inhibitor, especially the boosted PIs, inhibits this enzyme. So what happens when this enzyme is inhibited? So the level of the statins will increase more than what we intended. So as a result of the increased levels of the statin, this is where we will see the side effect of these statins coming into play, right? Such as myositis and so on and so forth. On the other hand, pitavastatin and pravastatin are not primarily metabolized by this enzyme. Okay, it is metabolized by other mechanisms. So their effect on this PI is actually less. So PI has the most interaction with statins, and it inhibits the drug-drug metabolizing enzymes and also affects the hepatic uptake transporter OAT P1B1. So it's definitely not easy to remember all that. So if you are ever in doubt, in Malaysia, in my practice, we rely a lot on our good friend from Liverpool. So our friends from Liverpool has developed this HIV drug interaction checker, which we find extremely useful. So they have been our good friend for many years. So if you want to look for the potential interaction, you need to check on what effect it will have. Some drugs when you want to add on to somebody who are already on antiretroviral therapy, we use this drug interaction checker. Of course, there are other drug interaction checkers that you can still use, but this is reliable. Next, let's look at this statin-induced muscle toxicity. Statins can cause muscle toxicity ranging from just myalgia to severe necrotizing myositis. But thankfully, this severe form of myositis is only very rare. It only happens like 1 in 100,000 cases in a year, right? So it's very, very rare, thankfully. And it is associated with this antibody, HMGCR antibody that is targeted by statins. All right, so now we know the issues, we know the problem, potential issues, and so on. So what do the guidelines tell us about this use of antiretroviral agents, and also when do we start statin, right? Let's look at the recommendation. So this US Department of Health and Human Service, HHS, they collaborate with AHA and also HIV-MA, HIV Medicine Association, and they come out with this guideline. So for people who requires high-intensity statin, I listed it down here. So for people aged 40 to 75 years old who has more or equal of 20% risk, 10-year AS-CVD risk estimate, it is recommended to start high-intensity statin therapy for them. On the other hand, for the younger patients, 20 to 75, if their LDL level is more than 4.91, then it's recommended to start high-intensity statin as well. By saying high-intensity statin, I mean Atova, like 40 to 80 milligram, or rosuvastatin, 20 to 40 milligram. So for people aged 40 to 75 years of age with diabetes, right? It's common in Malaysia and I believe some part of Thailand as well. Diabetes is a common issue. So it is recommended for them to be put on moderate intensity statin therapy and also perform further risk assessment using, and also on top of the high intensity statin, we have to assess the other risks as well and address them. If their 10-year AS-CVD risk is 5 to 20%, it is recommended to initiate a moderate intensity statin. Even if their risk, 10-year AS-CVD risk less than 5%, you need to consider moderate intensity statin. So what do you mean by moderate intensity statin? Well, it means here, as listed, pitavastatin 4 milligram once a day, atorvastatin 20 milligram once a day, or rosuvastatin 10 milligram once daily, right? All right, so how about those who are younger than 40 years old, where the risk isn't that clear, where their risk is not that high, LDL is not beyond the 3.91 that we just talked about. So the evidence does not show any strong data to recommend statin therapy for AS-CVD, for this CVD prevention in this group of patients. However, it is important for us to follow the general population advice, We need to focus and not to forget the lifestyle modification by focusing on diet, exercise, smoking cessation, and consider statin in high-risk population as per the guidelines. So now, Mr. B is concerned about additional pill burden if were to start on statin. Well, understandably so, as the patient is going to be prescribed an additional medication, additional cost, additional pill to swallow, additional task to remember when to take it and not to forget the other drugs. So indeed, it is a major challenge for Mr. B to juggle all this. So beyond the LDL, statin is found to have more effect beyond reducing LDL. It is found that it is an anti-inflammatory, it is anti-thrombotic, it has immunomodulation effects, reduces the oxidative stress, improve endothelial function as well as the vascular tone, and also it stabilizes the plaques. Seems like a lot of benefit from here. And the effect, besides lowering LDL, statin effect looks like it's beyond what is expected for LDL lowering alone. Having said all that and having mentioned about the benefits of statin, please do not forget about the traditional stuff, the lifestyle and also the traditional risk factors. Smoking, we have to always explore if the patient smokes and try to put them to programs to help them in smoking cessations. Dyslipidemia, hypertension, we have to make sure like the blood pressure is within target and not to miss this risk factor of cardiovascular disease, as well as diabetes mellitus. We have to screen them for diabetes and make sure like they are also screened for the potential complications and end organ damage from diabetes. Coming to the last few slides of mine, in summary, HIV is a unique interplay between the virology, immunology, and the metabolic health. And we need to approach the patient by an individual approach. It has to be a tailored approach to manage cholesterol, to reduce their risk of cardiovascular disease. Having said all that, I think we should have a regular monitoring of lipid profiles in our patients living with HIV. We have to consider the initiation of statin. Of course, do not forget about the drug-drug interaction. And also, we have to include the other factors that might contribute to CVD by engaging other specialty like dietitian, physiotherapists, weight reduction specialists, and so on. We have to be comprehensive in our management and also to engage patients to actively participate in beneficial lifestyle interventions. And besides that, don't forget to consider or look into the regime of antiretroviral drugs that the patient is on. And if they are on some high risk of causing high LDL when their risk of CVD is already high, we need to consider changing of ARV regime to more friendly LDL friendly or cholesterol friendly drugs. So this is my last slide. Thank you for staying back all the way